This webinar on physician engagement and leadership for health system improvement, we've set out a number of learning objectives, so I just want to touch on them right now. We want to recognize opportunities and challenges related to the demand for physician engagement and leadership from a health systems perspective. We want to learn about the organizational dynamics of physician engagement and leadership, including structural dimensions and supportive processes. To understand the existing research gaps, explore individual determinants of physician engagement and leadership, and consider the policy implications of physician engagement and leadership at multiple levels. So as we go through the webinar, I do encourage you, because as I mentioned at the outset, we want to facilitate linkage and exchange among the participants. Please feel free to use that chat function to send some messages about your own experiences and strategies related to increasing engagement and leadership of physicians, along with your email or contact information for others to connect.
Louise.
So for this call, I'll quickly outline how today's call will unfold. I'll introduce the speakers, and we'll hear from both the researchers involved in the project and the policymakers.
Graham?
An overview of the research, the policy implications, and then we'll save the questions and answers to the end of the session. But as I said, do feel free to use the chat mechanism to make comments throughout and make linkages. So just highlighting that the evidence-informed healthcare renewal initiative was based on an integrated knowledge translation approach. And what this means is that we have the research questions being addressed that were identified at the outset by the policymaker, and the policymaker and the researcher, in fact, work together throughout the project, in this case, a knowledge synthesis, to bring together the results. So you're going to hear, again, both from researchers and the policymaker perspective. So our presenters today, we have from the Ministry of Health in Saskatchewan, Brad Havervold, who's the Executive Director of Workforce Planning. And he's been with the Ministry of Health for a number of years with different leadership roles in the medical services branch and other areas. He's got an interest in team engagement, the engagement of physicians in systems leadership and transformation, and the pivotal role that physicians play in leading transformative change in the health sector. And on the research perspective, we've got with us, first of all, Dr. Jean-Louis Denis. He's a professor at the École Nationale d'Administration Publique and holds the Canada Research Chair on Governance and Transformation of Healthcare Organizations and Systems. He pursues research on governance and process of change in healthcare organizations and systems, and his current research looks at integration of care and services, healthcare reform, medical leadership, and leadership in professional organizations. He's a member of the Royal Society of Canada, a fellow of the Canadian Academy of Health Sciences, and was a chair of the advisory board on CIHR's Institute of Health Services and Policy Research. Leading this project with Dr. Denis is the co-principal investigator, Ross Baker, who's joining us from the Institute of Health Policy Management and Evaluation at the University of Toronto. Dr. Baker's research interests include patient safety and adverse events, quality improvement, organizational theory and behavior, organizational culture, performance measurement, and balanced scorecards. So I want to welcome and thank our three speakers today for joining us. And at this point, I'd like to turn things over to Brad Havervold to provide us with some of the context for why this particular knowledge synthesis was undertaken and some context from the Saskatchewan Ministry of Health perspective. So over to you, Brad.
Thanks. Can everyone hear me okay?
Yeah, I can hear you well.
Okay, great. Thanks a lot. Thanks for the opportunity to be part of this webinar today. As Jennifer mentioned, this goes back probably 18 months or so when we were working with CIHR on some information that we were hoping to gather through the expedited knowledge into this. So we do want to thank CIHR and its partners for the support here. The health system in Saskatchewan, as I'm sure it is in many other jurisdictions, is going through a significant amount of transformational change. We have 13 regional health authorities that are increasingly thinking and acting as one, planning integrated service delivery models amongst the 13 regions. We have a coordinated approach to the priorities of the transformation agenda, grounded, of course, in lean, which is being permeated through all sectors within our health system, hospitals, long-term care, community-based services, etc. As well, we have a number of clinical transformation agendas, including our surgical initiative to reduce the wait times for surgery to 3 months maximum by the end of this fiscal year. Embedding primary health care and transforming the primary health care system, eliminating emergency room department waits by 2017, and a lot of other ancillary things around appropriateness and so, for instance, the introduction of clinical pathways and that sort of thing to standardize care. So we realized as part of the transformation that we needed to do a better job of physician engagement, and we needed to better understand what that meant as well. We did have physicians involved in different types of transformation agendas, and it wasn't seem to be producing sort of the level of engagement to the front line that we were hoping that it would. And so what the purpose of our asking CIHR is, I really wanted to understand what is the published literature saying around what are the levers that support or work against physician engagement, particularly in a transformation agenda, but in any type of a change or a service improvement or a service realignment type process. So what are the things that work? What are the things that don't work? We make assumptions, I think, that, if we put a physician in charge of a change, of changing a process or leading an improvement or implementing a pathway, that somehow that should automatically lead to engagement. And we know that that's not worked for us. We know that in some cases we have a different language, I guess, used between physician community and the non-physician leaders within our regional health authorities, talking about the same goal but approaching it slightly differently. So what are the levers that bring those parties together to better sort of understand each other's perspective and to gain commitment on I guess, if some of you would be familiar with the compact principles of gives and gets. What do you give and get in order to achieve a goal? So that was really the context that we provided to CIHR and the researchers, and I think what you'll see today is some affirmation of the things that we found in our experiences, but also some interesting tidbits that we can, I think, all learn from. Again, we're not. I'm not with a specific hospital, and so I think some of what you'll hear today can actually be translated right down to the clinical service line area, and I think the principles are fundamental. I was looking at it more from the province-wide perspective of major transformative change that impacts everyone in the system. How does physician engagement and leadership help drive transformation, support transformation, but also create engagement right to the front line? So that's a bit of the context of where we were and are. So that's it for me.
Okay, thank you, Brad, for that context. And at this point, we're going to pass the ball over to Jean-Louis Denis and then to Ross Baker. to cover some of the research aspects of the project.
Jean-Louis, are you on the line?
Do you hear me?
Yes, we do.
Okay, thank you. Thank you. So I guess it's my turn, so thank you to be here today, and I will try to cover the main message that we extract from the synthesis, and I will share the presentation with Russ Baker, who came in along the way. So just want to thank briefly our founder, IHSPR, partner, Saskatchewan Ministry of Health, and the Canadian Foundation for Health Improvement, who provide support to organize a policy workshop along the way. So it's a broad research team who is responsible for the synthesis. I won't name all the people, but just to mention that we had clinicians on board too on the synthesis team, and some people who work in regional health authorities. So we had a kind of balanced team between investigator and a practitioner or people that live with the issue of physician engagement in their day-to-day life. The synthesis is based on a broad set of area. We cover 8 domains of inquiry. Again, I will not name them in detail, but just flag some of the more important, like we pay attention to work on high-performing on the organization, quality and safety of care. And also we look at elements of physician role identity and role conflicts and skills and competency development, and you will see along the way that our main message are articulated across these domains. You can look for methodology in the report, so just to say that we retain at the final stage 202 paper, and these papers relate to conceptual work and empirical work, so we have some broad criteria to select paper, but we did not limit material just to an empirical paper. So just some definitional work, like when we talk about leadership, we refer to physician in formal leadership position, but also physicians that act as leader for others in their day-to-day working life. And engagement refer to the active interest and participation of physicians in organizational and system improvement initiatives. And they are not seen necessarily as leader, but you will see along the way that engagement and leadership are complementary aspects of physician involvement for improvement. So we structure the synthesis around 3 key questions. How does health system evolution affect engagement and leadership of physicians for health system improvement? So this question relates more to the broad policy context. And the second question is, how does organizational context provide a facilitative context for physician engagement and leadership? And I will say that a big part of the synthesis focus on this aspect. And the third one is skill and competency for physician to develop physician leader. And just around this question, we were not interested in at an individual level of analysis. We were more interested at strategies at organizational and system level. So if around the first question, I will limit my comments on the kind of responses that health system or organization defined more traditionally to respond to pressure for more physician involvement and leadership. So in the literature, it is mainly discussed as structural strategy, and the strategy deal with two main components, some organizational design feature like involving physician on board, creating formal executive or senior leadership position for physician leader, or implementing diet management structure. As you know, co-management become more and more popular now in many provinces, including Quebec. And we include also in the structural strategy the participation of physician on quality council or formal quality committee in organization. And there is also here the question of incentive, which we put under the category of structural strategy. And one of the main messages around this is that while incentives are important as a supportive or reinforcing factor, it is not the key element to support engagement and leadership, and we will come back to this. So the main message here is that incorporating physician into organizational structure is necessary, but not a sufficient condition to successfully engage physicians in the redesign of healthcare process and system. So the key, I guess the key insight here is that organization or system need a portfolio of strategy. Structural strategy are important, but it's only one part of the story. Then we move to the second question, is how does organizational context provide a facilitative context for physician engagement and leadership? And here we refer more to organizational dynamic or process strategy. It's more, if you want, the soft side of the strategy, and the structural is more the hard side of the strategy. So we extract from this literature 4 core process or organizational mechanism. One is, as Brad referred to before, is physician compact. And a physician compact really is a mechanism that organization can use to become more explicit about mutual obligation and expectation between physician as a group and the organization. So we label it as a renewal of the social contract between physician and organization. And in the Canadian scene, Ottawa General Hospital is often quoted as one plausible example of using physician compact for engagement and leadership. The second item, which is in a sense a broad set of strategy, which deal with creating more receptive or facilitative context in organization, and we identify various elements around work on quality improvement initiative and work on clinical management system or clinical microsystem. And one of the key insight here is that clinical microsystem, which means the immediate context in which physician work, is a fertile ground to develop strategy for engagement and leadership. And the second aspect of it is that frontline clinicians control part of the lever to generate improvement. And you may have all sorts of strategies at the more strategic level, but you need to build something around this clinical microsystem to really improve care. And the third item is seeing leadership not as an individual property. As you know, professional organization or healthcare organization is what we call a distributed environment, where a large set of people has expertise, influence, and legitimacy, and in order to mobilize these assets to improve care, we have to develop a mindset that value a more distributed form of leadership. Concretely, it means trying to have physicians at the strategic apex of the organization as leader, but also cultivating clinical leader at all other levels in the organization. And the collective aspect means developing strategy to work collaboratively between management and the clinical ward, for example. And the fourth item here is team-based organization or teamness, this idea that physicians don't work in isolation but work in team. And team is seen again as a fertile ground for physicians to develop leadership role for clinical improvement. So that was the four core process that we identify at the organizational level, and these processes supplement, in a sense, what we identify at the structural level. And saying differently, you need this process to nurture the kind of strategy that you may develop at the structural level. So I will now leave the micro to Ross Baker, who will conclude this section and move to skills and leadership development section of the synthesis.
Okay, so Ross, we're just passing the ball over to you now to finish with the remainder of the slides. So you now have control.
Ross, you may want to do *7 on your phone to unmute it, please. Or there might be a mute on your telephone.
Okay, is that good?
Yes, we can hear you. Wonderful.
Okay, thanks very much.
As you can, please, Ross.
Okay, so what I want to do is sort of continue on this analysis that Jean-Louis started, and we're really staying at a fairly high level in terms of understanding the themes and issues that emerge from this very complex and widely sort of spread literature in many different journals, many different areas. But the main messages, just to reiterate what Jean-Louis has said, is first of all, physician leadership, physician engagement are critical elements to system transformation. I think we all recognize that. It's how you do it and how you create a broader strategy. So I think we've, for many years in many different settings in this country and elsewhere, seen individuals who've stepped forward in leadership roles at various levels of the healthcare system, but that's insufficient, I think, to create a collective will to actually move forward and to build the sort of linkage to clinical colleagues, both physician and non-physician colleagues, to make a difference in the system. So one of the things that emerges from this literature is that we shouldn't think about leadership and engagement as two separate issues, but as a connected and reciprocal kind of dynamic. If you have effective physician engagement, you create the opportunity to identify and develop leaders within different settings. And if you don't have engagement, then it's very hard to get that kind of leadership, and the leadership that you do have has a hard time actually moving the agenda within the organization. So that forces us to ask the question, how do we create this facilitative context? How do we create an environment where physicians see their role as broader than simply clinical practice, although that remains a obviously critical part of what they do? And how do we then create systems that select, develop, and engage leaders to move those systems forward? So we need to move from a situation which we've all seen in various settings, where you have lonely leaders, chiefs of service, VP medical, at various levels of organizations who don't have an effective dialogue with other leaders and with the clinicians in the organization. So leadership needs to be a broad distributed process. It needs to be linked. Leaders need to be linked from the front line of care to senior levels with strong communication, shared vision, and collaboration. And one of the, I think, critical insights that we saw in the literature was this idea that if you really want to create a strong leadership team, instead of starting at the top, which is what many places do, where they say who's going to be our senior visible physician leader, we should start at the bottom and say how do we create those frontline teams and microsystems of care, make them effective, and identify and develop the leaders within them. So the next question is really, with that as a context, is thinking about, so what skills and competencies do physician leaders need, and how are these best developed? And this is a policy question that people are looking at many different levels in many different provinces now, and the medical associations, the colleges, regulatory colleges, the certifying colleges, regional health authorities, and others are all asking this question. So what do we want from our physician leaders? So we've moved a bit from this question about who to the question about what skills, what knowledge, what values do we want in this. And we went through the literature, and again, remember that our lens here is on system improvement, system transformation. And these are some of the competencies that emerge from the literature. And so it's not really surprising that you see these strategic planning, systems thinking, change management issues. These are the things that distinguish all leaders who are engaged in system transformation work. And so the real challenge here is to figure out how do we link these competencies and develop physician skills in these areas so that they can be fully conversant with these skills and to act effectively with their partners at whatever level of the system that they're providing this leadership. And one of the questions that some of you might be asking, so how do these competencies reflect on and contrast with the existing competency frameworks that we have, the LEADS framework, for example? And I would say that there's a lot of synergy here in terms of system transformation, achieving results, and developing coalitions as critical elements. And it's not just the Canadian framework where there's a consistency here, but I think also we'd see that in the English and U.S. framework as well. So this is, I think, a useful partial list of some of the critical system level, system change competencies that are necessary to really create effective leadership from physicians. But we also need to see this as something that is not apart from but linked to the other competencies that physicians need in their work. And so rather than seeing these competencies as separate from the clinical skills, the knowledge that the physicians bring to their clinical practice, we need to ask the question, how do we link this to those skills as well, so people see a natural evolution and natural development in these skills as building upon, augmenting their existing skills, knowledge, and values. And I think that if we do that effectively, that provides another way in which we create an avenue from the role of physician as a leader at a clinical level, at a frontline level, to the role of physician as a leader in the broader system level. So we need to stop having this sort of bifurcated view of the organization where we have relatively few representatives from the medical profession who sit with this broader systems view and start to ask the question, how can we now create the systems view more generally for people who are going to take roles at whatever level of the healthcare system. And that, of course, is not a new view. That's the view that many of the medical school educators are really sort of grappling with now. How do we create within the already busy medical school curriculum the opportunity to develop those kinds of leadership skills? And some of you probably know that CanMeds is undergoing a revision that sort of builds on this idea about the generalized knowledge, skills, and attitudes that are necessary to give physicians the leadership roles that are going to be a part of an effective, high-performing healthcare system. And that the notion of competencies then leads us into a broader thinking about the nature of physician leadership roles and the kinds of skills that are necessary within each one of those roles. And so just a list this builds on some work from Australia, Alison Dyer and some of her colleagues who went out and started to re-examine the kinds of roles that physicians needed to play in a system that was really oriented towards trying to get wide-scale improvement. So the first role, leadership and management of medical staff, really talks to the role of physician leaders as negotiators, as translators of the bigger picture, and integrators, so that there's a sense of how the local clinical agenda, the local work of microsystems, links to the broader system agenda. And we often, I think many leaders often fail to make that very clear or fail to have people appreciate the messages that they're trying to communicate. So it has to be a top-down and bottom-up strategy. There has to be a message from the senior leaders as well as an appreciation and translation at a local level of what those messages mean, so people see how their work fits into the larger agenda. And related to that, secondly, is the strategic and organizational development roles, the extent to which we can create strong physician participation in the development of strategy at the macro level, at a provincial and regional level, so people see the important role of engaging physicians in the development of strategies. And I think Brad may want to comment on this later on, but I think this has been an ongoing agenda item in Saskatchewan, and they've tried very hard. They've invested a lot in identifying physician leaders and trying to bring them into this discussion about how do we create a more effective system, how do we involve the physicians in the lean initiatives and the surgical care initiatives that have really been at the forefront of some of the work that the ministry and the regions have been doing in Saskatchewan. The third issue in terms of physician leadership roles is the clinical governance role. And I think this is becoming very clear now that the way to engage physicians in broader leadership roles is to appeal to their natural interest in and instincts for improvements in the quality of care and patient safety. And so creating champions for clinical governance is an obvious and attractive opportunity for many physicians who otherwise don't see leadership as something they want to get into. And so it becomes a mechanism or a pathway, if you want, for broader leadership development. If we can identify ways in which we can develop the skills, knowledge, and activities of physicians engaged in quality improvement and patient safety to help them take a leadership role in that and to link then their knowledge and roles in clinical governance to broader system roles. And lastly, this is the issue of roles in operational areas. How do we help physicians who get involved in helping to translate the bigger organizational strategies, to implement changes in service delivery, to start to redesign the relationships with other providers, both within the organizations and they work and in the broader environment. We all know that transitions of care are very important, and we can't create effective transitions unless we have physicians involved in helping to redesign the way in which that care happens. So the main message here around competencies and roles is really that we have to see this in a system or organizational context. We have to think about the ways in which we now try to integrate physicians, to give them the skills and knowledge to allow them to be full participants in decisions about service redesign, to help understand how to translate those patterns of service redesign into local initiatives that really help to make a difference in the delivery of care. There is a theme in the literature about economic incentives, and our sense looking at that literature is that there's no strong evidence that economic incentives alone actually make a difference here. On the other hand, it's very true that in many times the payment systems do not support physicians in taking on leadership roles. So we always have to ask the question, how do we prevent physicians from being penalized economically for their participation in leadership roles? Let's just make sure those systems aren't discouraging their interest and their participation in those kinds of initiatives. So let me just conclude by saying a little bit about these overall strategies from this very diverse and widespread literature across a number of different countries on strategies to enhance the engagement of physicians and their leadership for health system improvement. first of all, it's pretty clear here that there's no simple panacea. There's no magic bullet. If there would be, I think we would have discovered it right now. We need a diversity of strategies to engage physicians. We need the structural strategies, which were, I think, the things that we latched on initially because it was easier just to appoint somebody in a leadership role and to give them a budget and a title, and then to say, go engage your colleagues in the work that we need to get done here. And what we've seen is that by itself is probably insufficient in most circumstances to make a difference. What we need is a broader engagement, a broader development strategy where we're targeting not just a couple of individuals, but targeting larger groups of individuals and giving them a sense that there's an ongoing opportunity to develop, to take on different roles, to develop leadership and develop sort of leadership systems rather than individual leaders within broader systems of care. That's going to require some significant investment, I think, in our healthcare organizations, but my sense is looking at the literature at some of the larger healthcare systems in the U.S. who have done this, that those kinds of investments pay long-term dividends. So we need to revisit current structures, the current professional development plans, and to move beyond the patterns of individual development, which have been characteristic of most organizations in this country, to develop a broader system of leadership development for physicians, and I would say also for other clinicians within those organizations who are also not always well served. It's also clear that leadership strategies are not effective in an environment that's characterized by mistrust and the isolation of a few leaders, physician leaders and physician managers in a larger environment which doesn't seem to value their role. So we have to create a different context if we really want leadership engagement to happen, to move beyond the current situations. And one of the frustrations in the literature is that most of the literature deals with organizations who have been successful in doing this, but they talk more about their current state than the transition into the current state. And so we need to go back and ask the question, how do we turn these organizations around? And Jean-Louis talked about some of the mechanisms that are useful for doing that, including the physician compact and other ways that we can now reestablish the social norms and the common commitment of people from different perspectives, managers, physicians, other clinicians, towards creating better care for patients and for their families. So this is difficult work. It requires us, I think, to really think very hard and to work collaboratively to develop these kinds of strategies. I think I said this before, and I think it's worth repeating, is that we often start at the wrong level. We start at the most senior levels of organizations, and really we should be starting to create and to really encourage and support those effective clinical microsystems and to help develop leaders within those systems, because they become then the candidates to take on broader roles in our organizations. So educational strategies are critical, but leadership development has to happen within the organizational context, in the work environment, and it needs to be linked to the development of better systems of care, giving physicians an opportunity to focus on ways in which they can help to make improvements in care and create an environment in which other leaders, other individuals want to step forward. So I'll stop there and turn it back to you.
Okay, thank you very much, Ross and Jean-Louis. We are going to hold questions still for a little longer. We're going to hear again now from Brad, and with just some thoughts on policy implications from this particular project and some of the work and next steps for the Saskatchewan Ministry of Health. So back over to you, Brad.
Thanks very much. Can everyone hear me okay? I'm assuming so.
Yeah, we can hear you, Brad.
Great, thank you. So some of the work that we're continuing to do around physician engagement it's scattered amongst various initiatives. I think what fundamentally we've determined, and although this should be pretty common sense, we've determined that within each of our change agendas, whether it's happening at a very local level, at a community level, whether it's within an individual hospital, or whether it's a provincial change initiative such as the emergency department waits, project, there needs to be a very specific and articulated physician engagement plan for each of those change agendas. So I think that one would naturally assume that as you're introducing change that potentially impacts physicians and or patients, that it should be second nature to do physician engagement or to engage physicians in that. And oftentimes engagement appears to be well, we've sort of developed a plan and now we're wanting to see what you think about it. We're involving physicians more right at the outset of identifying what the problem is, brainstorming solutions, and coming up with ideas about how to have that happen. And in some cases, physicians are taking leadership roles within those change agendas and helping to sort of bridge the gap between the medical community and the non-medical community, and then in some cases to academia. So the embedding of an articulated physician engagement plan within each change agenda is becoming something that's mandatory within our province, and particularly using the strategic planning approach that we have amongst all of our health regions. We're all using one approach, coming up with one strategic direction provincially, and then everybody cascading and marching in the same direction. It's working well. Some other things we know that some of our program areas within hospitals and within some of our regions are looking at dyad leadership models. Now, this isn't just simply, as the researchers spoke to, about sort of appointing a person in a leadership role and then having them sort of just there as a figurehead. This is about true dyad leadership, where physicians are involved along with their administrative leader in planning care delivery models, and planning budgets, in planning change agendas, in planning priorities for that service line going forward. So, and I presume that many of you will have dyad models within organizations or within your service lines already, but our experience is that can be quite effective and help to engage particularly the physicians that are serving patients in those service lines. There is some work being done within regional health authorities and programs around the use of compacts. Certainly none to the extent yet of what we've experienced in places like the Ottawa Hospital, where they've done a considerable amount of really good work. We've certainly learned a lot from their experiences and others about that. Virginia Mason Medical Center in Seattle is another one that we're modeling on. We're sort of experimenting, I guess, if you would, with the concept of compacts more at a local level, particularly in service lines where there may have been challenges with expectations of physicians and expectations of administration from physicians, et cetera, to really get a clear understanding of about who's bringing what to the table and what do we each get from the table. We're also looking at things like distributive leadership, of how do you, within change agendas, how do you cascade information and build engagement and build leadership and buy-in right to the front line, particularly with physicians. And I'm going to speak in the context of physicians here because that's where we've had some of our major challenge. I think you can also apply these same concepts to other staff and other providers that work within systems. I think sometimes we make the assumption that those nurses and therapists and technologists that work within health systems simply by virtue of their employment are engaged, and we know that's not to be the case. So I would suggest most of what can be applied here can be applied to non-physician providers as well. We've made some very conscious efforts to have physicians involved in decision-making right at the highest levels. We have a chief medical consultant within the Ministry of Health, which really is a partner with the deputy minister, advising on clinical strategy, the impacts of change from a clinical perspective, and sort of providing that lens, bridging the medical community sort of right into senior decision makers within the Ministry of Health. And certainly each of our regional health authorities has a senior medical officer who has some administrative responsibilities, but increasingly you're seeing people in senior clinical leadership roles really at the senior leadership tables of those organizations, bringing physicians' perspectives and clinical governance to life. So we've engaged our physicians, particularly in things like our lean leadership and our lean journey. I'm not sure how familiar you are with Saskatchewan's engagement in lean, but certainly it is the improvement methodology that's being embedded in all of our service lines, in all of our hospitals, and all of our long-term care facilities. And along with that comes lean leader certification with the consultant that we're using that has actually developed some lean work with Virginia Mason, with Seattle Children's Hospital, and I think some of them have some experience with Theta Care in the U.S. as well, that we have for leaders in the system and even frontline managers, et cetera, a lean leader certification initiative where sort of over the course of 18 months people take didactic and clinical training in lean development and the understanding of lean tools and actually applying that knowledge in leading rapid process improvement workshops or PDSA cycles that some of you might be familiar with. So the process that we've used over 18 months has engaged some of the non-physician staff around 56 days in order to make this sort of palatable, if you would, to physicians who most of our physician leaders also have part-time or more than part-time clinical practices. Is we've collapsed some of that training down for physicians to the important roles that they play within some of those rapid and process improvement events. So we've collapsed their training down. We've implemented, we were able to negotiate with our medical association in the last round of collective bargaining a quality improvement fund that actually pays physicians for their time for participating in quality improvement activity, whether it's at a regional or provincial level. So certainly all the physicians that participate in rapid process improvement workshop looking at reducing waste or improving processes within regions and engaging improving quality would be compensated for their time. We do know that in some cases it doesn't necessarily keep them whole. It doesn't necessarily, it's not necessarily income replacement, but certainly it is a way that they can, those that have office practices do not, they're at least able to keep their overhead costs covered as well as, maintain some level of income. So that is one thing that we've found that has been very helpful. It doesn't pay them excessively. Again, it just is intended to sort of make sure that they're not losing money by participating in quality improvement activity. We do know that we've got our regional health authorities have collaborated using the LEADS model, developed a leadership development program that is largely subscribed to by non-physician leaders, but increasingly being subscribed to by aspiring physician leaders within regional health authorities. And we've been able to collaborate between the Medical Association and this leadership program to sort of marry the best of both the Physician Management Institute, the PMI programs that are out there, and the Regional Health Authority-based program and do some serious collaboration. What we've found over time is that physicians support PMI and they're interested in taking PMI courses, and Regional Health Authority leaders would be taking other leadership development. When we know that if we are wanting partnerships throughout the system, if we want to build engagement, improve trust between the physicians and non-physicians to really create a culture and an environment of improvement, that people should be taking training and development together. So, we're trying to marry those two programs. And the Lean Leader certification that I spoke to, whether you're a physician, frontline nurse, CEO of a health region, you are participating together, you are leading and participating in rapid process improvement workshops together. So there is no sort of there's no level of hierarchy, if you would, that automatically puts the physician in leader. Sometimes they're the participants in the process, and sometimes they're the leader. At the end of the day, everybody contributes, and everybody's ideas generate and contribute to the improvement. And what we're finding is significant improved engagement. We're about to embark on some measurement of physician engagement with system transformation, both staff and physicians. And that, again, when our provincial leadership team, which includes CEOs and system leaders, both from the ministry and elsewhere, they monitor metrics at least quarterly about where's our transformation agenda, where are we hitting roadblocks, how do we collaborate to make generalized improvements. And finally, I'd say that provincial leadership team that I just described to you, we actually have enhanced physician participation in that committee. So we have the president of our medical association. We have a number of frontline practicing physicians as well as senior medical officers within regions that work with both regional health authority board chairs and others, as well as regional health authority and system leaders, to set the agenda, articulate what the improvement ideas are, what the priorities should be. So it seems like a bit of a scattering of activity, but I say what we do is try to embed it in all that we do, and we're continuing to just advance it as we move along. It's a culture change, and as you know, culture change simply just takes time.
Okay, thank you so much, Brad. That was really a good summary, and you touched on many different points that I think each of themselves could be a whole separate webinar, like your experience with Lean, the economic aspects and physician reimbursement around the physician leadership aspect, and of course the whole component of measurement of physician engagement. So thank you very much for that. I think that you've given lots for participants to think about. I'd now like to open up the discussion. I invite you to use the chat mechanism to post questions, and then what I will do is read them out and address them to the appropriate panelists. So as you're formulating your questions, I just want to highlight that we do have the final report of the synthesis. A link has been sent in the chat box, so you can all access the report from the synthesis there, as well as other syntheses that have been completed through the Evidence-Informed Healthcare Renewal Initiative. So I encourage you to go there and check that out. And I'll also just mention that we will have the recording of this webinar and the slides available to you afterwards. So I'll just read out one of our first questions here. This one is for you, Brad, from Joshua. How is PMI leadership and lean training being integrated in Saskatchewan?
I would say that at this point it's not specifically articulated. What I would say is that we know that the leadership development program that is being developed and in place from our regional health authorities, which includes physicians, they are, as I mentioned earlier, increasingly collaborating with PMI. We also know that they're bringing in and they're weaving in lean concepts into that development, but they also know that the lean leadership certification that I spoke to, that 56 days and that 23 days or 22 days for physicians, it has been married up against the leadership development program, so that they articulate quite different focuses. So the leadership development program generally in PMI will give you some general leadership development based on the LEADS framework of sort of self-awareness, leading others, communication, those general leadership things that we're all familiar with, whereas Lean is very focused on the Lean tools and engagement of staff. So a lot of times what we'll be looking for is people that go into Lean Leader certification will already sort of have the ground knowledge of basic leadership. So I wouldn't say that it's completely integrated yet, but there is a laddering, if you will.
Thank you, Brad. Another question also for you, Brad, from Shalom. How are you involving patients in this leadership effort?
I would say that patient engagement and patient involvement is fundamental to all of our change agendas. So whether anything that is introducing a fundamental change to a service line or a program within one of our health regions, or even some of our major provincial initiatives like the surgical initiative, has patients both, they're at the ground at the development of understanding the problem, brainstorming solutions. So patients are part of every one of our change teams right through. In terms of how are they engaged in this leadership effort specifically, in terms of the leadership development of our leaders, I don't know that there's a lot of patients participating in that, but I would say anything that impacts the clinical world of patients has patient involvement completely embedded in it. Ross, I don't know if you want to add anything on. I know that you're on the board of our Health Quality Council and might be able to also share some, from your perspectives, the amount and the extent to which we have patients involved.
Well, I think you summarized it nicely, Brad. There's a growing interest in involving patients in the system-level changes and to making them part of the decisions, both in the rapid improvement events, the lean events within organizations, as well as more broadly. And Liz Crocker, who's one of the sort of key advocates for patient and family involvement, has just joined the board of the Health Quality Council, and I think there's a sort of a general sort of thinking that these strategies need to become integrated into the broader system transformation strategies. Okay, great, thank you.
Another question from Hawa. How early can education around physician leadership and engagement start? So could you comment on the role for medical schools in their engagement?
So I can say a little bit about that. I mean, I think the problem we have faced is really the challenge that people enter medical schools with a principal interest in learning the clinical skills that they need to develop in order to be effective physicians. At the same time, I think educators see the need to put those clinical skills in a broader system context so that the physicians see themselves not only as clinicians, but see themselves as managers, leaders, communicators, and participants in the broader system changes. And so the challenge for medical schools has been to sort of balance that tension. And I think there's an increasing number of experiments around that. I mean, I can't speak for schools across the country, but I know the University of Toronto has been developing leadership programs within the undergraduate medical curriculum, trying to give at least some portion of the class some exposure to that leadership training. I think with a long-term view of sort of extending those opportunities, partly around understanding how physicians can be leaders in the improvement of care, which gives them, I think, people insights into how they can be leaders more generally in the organizing and delivery of care. So I think there's a growing interest in the broadening of the competency set. And, you know, the CanMeds framework has a pretty broad orientation already. So I think the Royal College is certainly interested in helping to push that to the next iteration and making sure that physicians don't emerge from training without appreciation of their broader roles in the system.
Okay, Jean-Louis, maybe just an addition to this. I think one of the results of the synthesis is that the experience of work, the experience that physicians get in their day-to-day life in the organization is very important. So there are gains to make during initial training, but also it needs to be nurtured and reinforced in the work context when physician practice. And I think what Brad presents is a clear example of this.
And thank you, Jean-Louis. So we have a couple of comments from Pamela. This comment is based on their experiences implementing patient-based funding into Ontario hospitals. And her comment is that it's important to consider how physicians engage and lead when their actions are directly related to generating revenue for the hospital. Any comments from any of the panelists related to this comment?
It's Brad here. I'm not familiar with your funding model, but it's interesting when you look at physician engagement in some of the American locations that we've seen, Virginia Mason in particular, about how they've used lean and other tools to engage their physicians, and obviously they need to be able to generate revenue. Yeah, it's an interesting concept. I'm not familiar with Ontario's model, as I said, but certainly within our jurisdiction, hospitals are not funded based on the funding is not directly related to increasing patient volumes, even though that can be a net effect the subsequent year. But I think what we're trying to do is to improve the quality of the patient experience and quality of care, which is something that physicians have a keen interest in. And then just by virtue of that and reducing waste through lean, you tend to see that general sort of engagement and the improvement of the bottom line. But I don't know, Ross, you might be more familiar with the Ontario model and could answer this better.
Well, I mean, I think Ontario is not that different than Saskatchewan. I mean, there's some volume incentives, but basically most of the system leaders are trying to figure out how to use their resources effectively to provide the care that they can get, and additional volume is more a strain on the system than it is a benefit. So appropriateness becomes an important issue in there, and that requires a lot of engagement of physicians to really understand the ways in which we can make decisions about what patients should receive what services.
Okay, thank you. I noticed there's some comments coming in that the audio is problematic, so hopefully that's getting fixed here, but it seems to be okay from our end. But if you are having issues, please comment through the chat. We'll see if there's something going on here. So another comment from EMAD. I noticed the frontline and general practitioners, especially in rural areas, are not really involved in the policies and requirement needs of their workplace. I suggest that their opinions and views be taken into consideration periodically. Any comments from the rural perspective, Brad, from the Saskatchewan, your experience in Saskatchewan?
I completely agree. As you know, Saskatchewan is fairly the population's dispersed, and we do have physicians in lots of communities, as do most provinces. What we try to do is work again through our regional health authorities, and I think what's important in relation to that comment is changes and improvements that you can do at a local level need to involve the local people. So if it's a change to, say, a service line within a community hospital of a community of 5,000 people, having the physicians and the staff that are in that area understand what that change is, what needs to be done to improve it, and empowering them to make that improvement using lean tools and other, that's what I guess we expect within our system, is that the frontline providers that are closest to the care have the best knowledge of how to make those improvements. And of course, within what resources allow and you know, legislation and policy, make the changes that they need.
Thanks, Brad. A question or comment from John. How do we bring back a trusting environment in which engagement can develop safely? With some form of decentralization rather than over-integration into huge systems, for example, the ongoing AHS experiment and others, be beneficial?
It's Ross. I mean, you know, so there's really two questions here. There's the question about how do you create trust, which I think has to happen on a local level. I agree with John's comment on that. And the second is how do you create effective local conversations on these issues when you're part of a much larger system. And I think, you know, the reality is that most care happens in small microsystems that then have to connect around coordinating care for patients with other microsystems. But, you know, if the trust doesn't develop within the microsystem, it's not going to develop anywhere. So the opportunity is to think more explicitly about how we develop the skills and the collaboration. And it's not just physicians, it's obviously all the clinicians and the patients and families involved in here at a local level. And there's lots of good examples of places that have now been working at that level, and it pays huge benefits across the system as a whole. So even when you're part of a larger region or provincial-wide, I mean, there's often opportunities to start to do useful things at a local level.
Jean-Louis, I agree. It's not, in my view, the overall size of a system. Is how a system work with their clinician that is probably more important.
A couple of related comments and questions around the focus on physician engagement vis-a-vis other health professions, but from Ty and Shalom. Curious to know why the focus on physician engagement in leadership as opposed to being more inclusive of other service providers. Within interprofessional teams, one of the challenges of effective collaboration is hierarchy and lack of trust. If the focus continues to be on physicians being the clinical leads, would this not aggravate this particular challenge to collaborative care? And Shalom's comment was, how does this competition between professions affect the development of physician leaders?
It's Brad here. I might address that at one point. I think we completely understand and appreciate that this is about the team, and in fact, that's where our system is grounded, is in the team. When we talk about rapid process improvement workshops, quality improvement activity, involving people in change, this is about involving everybody in making a change that is impacted by that change or has some influence within that change. So I think why we've done some specific focus on physicians is that physicians, by and large, are independent providers. They have a relationship with the system for admitting purposes or for accessing diagnostics and surgical services, that sort of thing. But they are not directly sort of, they can succeed as physicians whether or not a hospital succeeds or not in some cases. So it's how we realize that they are the ones that are perhaps most distantly connected, but yet have some of the greatest influence within whether systems change can proceed or not. And we recognize that bringing them into the fold and having them engaged in a transformative agenda is fundamental. So we know that it involves the broader team. I think perhaps the group that is most furthest away historically has been the physicians, and that's where we've spent some of our energy.
Yeah, that's very nicely said, Brad. I mean, I think it is a team effort, but many people recognize that the physicians are often minimally represented in what the team does, and then if they don't agree with what the rest of the team decides, they can veto it and or scuttle it in other ways. And so it's creating physician leadership for more effective care at a team level an organizational level and a system level, and that requires engagement. It requires an understanding of what it means to be a member of a team, a whole set of skills around this. And so physician leadership and engagement is not simply focused on developing the physician part of this. It's creating a more effective system. You cannot have effective, sustainable change unless the physicians are part of that change. And in order for them to be part, we need to engage them as members of the team and as leaders, co-leaders in the system.
But I agree with the question that it can be a source of tension. Like if I look at some conversation in an organization now, it needs to be bring on the table in a very explicit way, because some profession can, or some people can react negatively, recognizing at the same time the need to have specific strategy for physician engagement, but the strategy to combine this with a broader view of leadership with other professions is not always easy to find in an organization, and I think it's an important issue.
Thank you. It's Jennifer here again, and I see there's just a bit of a pause in the questions, and so not to cut things off at all, we still have a good 10 minutes. I just want to highlight that there will be shortly on your screen a short survey that we'd really appreciate if you could complete. Perhaps while people are thinking of other questions, you could take a few minutes to answer these questions, which helps give us feedback on these webinars and how to improve. Okay, so it'll be coming up in a minute. I see we have some other questions coming in as well. Okay, so a question from Nadia. In addition to the earlier suggestions of appealing to their interests and providing financial incentives, do you have other tips on how to engage physicians on frontline quality improvement projects?
Yeah, so I think Brad sort of covered this a little bit. I mean, we have to make physicians, give physicians the opportunity to participate in this, give them the opportunity to have the opportunities to learn about the skills and to engage in the skills. And we often start with sort of limited participation, but you know, if you have success in doing this, it breeds its own opportunities for growth. And I think that's the lesson we've seen in many organizations. It starts very slowly, and you have to encourage a few people who are willing to step forward to support them to be part of this, and then to share the results of that. And that's what many organizations have found is the success. It's often not easy to do, particularly if there hasn't been a tradition of physicians participating in these kinds of activities, and certainly it's difficult if they're taking time away from clinical care without any compensation. So you have to ask the question, what are the barriers to help physicians become part of this? And how do we give them a sense that this is not only useful for them, it's useful for their patients, it's useful for the broader system. And so it's developing that sort of different lens on the situation, I think is critical as well.
Thanks, Ross. So please do continue to submit questions. We still have some time, and I'll just mention as well, this is one of the IHSPR policy rounds, one of 4 that have been held to date. So earlier this year we did one on patient-reported outcome measures, one earlier this fall on activity-based funding or performance performance-based funding models. And just last week we did another webinar on governing the use of genetic testing. So I just wanted to mention that there will be additional webinars coming up in the new year, so stay tuned for those topics. And if you want to
Jennifer, I noticed there was a question on there that I'd like to be able to speak to. I think it was from Shalom. It says, do you really claim that physicians have been excluded? I don't know that in any situations physicians are particularly excluded, although there may be evidence of that in some situations. I think what we're saying is that physicians are often included, but they're included too late in the process. So oftentimes we identify a problem, we develop what we think is the response to the solution, and we ask them for their feedback, rather than engaging them in identifying the problem and exploring what those solutions are right from an earlier point. So that even though in sort of the situation that may have happened in the past where we took changes to them is not necessarily excluding them, it's not including them at the right point.
Maybe, Jean-Louis, just to add on this, I think in many cases there may be a lot of participation of physicians on different committees or with different consultation mechanism, but it's not done in a context where there is mutual understanding of expectation on both sides and obligation, and that may create the feeling also that they are alienated from key strategic choice in organization. So that's why we refer here to this notion of physician compact as a potential important mechanism for engagement.
So I see the question from Sam, but before I read that one, perhaps you could just address Shalom's follow-up comment around who the we is referring to, nurses, managers, policymakers. And I think that's just in response to your earlier comment, Brad.
Sorry, can you say that one more time?
Yeah, so Shalom's follow-up question was who, when you say we, who are you referring to? Is it nurses, managers, policymakers?
I just don't know in which context was it when I used the word we. I'd have to reflect on that. I probably used it several times. I guess when I use the word we like to think of ourselves as one system, that it would include, I know what it is. It's around, we haven't taken policy changes to them at the right time. So I'm using we in the broadest context, whether it's a nurse unit manager, whether it is a policymaker within a government organization, whether it's a CEO of a regional health authority or a director of some program. I think I use the we meaning generally.
Okay, thank you, Brad. So the question from Sam is, what is the role at the system level for physician accountability in driver engagement? In driving engagement, perhaps?
It's Ross here. I mean, it's a good question, Sam, and I think the part of the flip side of physician engagement is a greater understanding of the commitments that physicians make, both at a clinical level and beyond that, in terms of helping to make systems more effective. And we haven't done a good job of that in this country. We sort of created a bargain with physicians 60 years ago, and now we have to revisit it. What's the role? The role of the physician is more than just being at the point of care or member of a larger care team. It's taking responsibility to make sure we're using our resources wisely and helping our patients to make the best choice and being, collaborative with our team members. And so the question is, how do we help to reinforce that and to do it to create accountabilities that are consistent with those larger system goals as part of the answer. But accountability strategies are often seen as punitive rather than rewarding. So we have to really focus on doing this in a way that supports the larger directions we want to move in. I don't know if that answers your question, but I think it is an important element of this. It's part of the conversation about how do we create a broader system where everybody's moving in the same direction. That's
right.
why Brad talked about this a little bit. I think one of the important elements, probably not as recognized as the lean work in Saskatchewan, is this effort by the Ministry of Health to work with people across the system to create alignment in terms of goals and energy towards change.
Right. And specifically related to physician accountability, even though it's not, quote unquote, an accountability document, if you look at what a compact does, it's really a relationship charter between two or more parties that can really outline some terms of accountability. So if you look at Virginia Mason's website, I believe their physician compact is there. I'm not sure, but when it talks about, you know, physicians will as part of their give, if you will, is they will actively participate in quality improvement activity in the interest of patient or client experience improvement and that sort of thing. And in return for that, the organization will respect their input and advice on those kinds of things. So there's a bit of an accountability relationship built in there at a systems level, even though it's not sort of, if you would, sort of hard line accountability. It's almost a relationship charter and a commitment to each other.
Okay, thank you, Brad. We have two other questions here. One is, what is the role of performance measurement in physician engagement? I think you touched on this in your talk, Brad, and some of the measures you're going to be implementing.
Performance measures in physician engagement. Yeah, so when we look at the work that we're doing around our transformation agenda, so for instance on the surgical initiative, it's under the guise of sooner, safer, smarter. So it's about the wait times, but it's also about safer, implementing things, for instance, like the surgical safety checklist, and the smarter piece is more around working more effectively, appropriateness, using things like pooled appointments and group referrals, that sort of thing. What we found is that when you measure at a provincial level, but they also measure those same metrics at either a facility level, a regional level, or sometimes even at a medical department level, people, when they see their data and they see how they're performing both within themselves and against each other, those are significant drivers for physicians to want to improve. Our experience is that physicians like to see facts and hard data, and they like to see where they sit in relation to others, because I don't think anybody comes to work any day wanting to necessarily do a bad job, and they're always looking for ways to improvement. What we've not done in the past, perhaps well, is shared that information well and had a conversation at a very visible level. I don't know, Ross or Jean-Louis, you may have found something else that appears in your research.
Well, I think performance measure and management are seems key in the literature as a way to, in a sense, making very concrete some expectation and also providing an opportunity to improve care, like by providing good information. So it's not just an accountability or control piece, it's also providing a context in which physician and other clinicians can work on improving care by having proper indicator and information.
Okay, thank you, Jean-Louis. We have time for this one last question from Angie. When recruiting physicians for research projects or any project that requires data collection of their patients, one challenge that has been encountered is that they want to know what will be done with the data. So from a research perspective, we're trying to fill a knowledge gap, but in terms of how administrators or senior executives might use the data, we can't say for sure. I don't think the administrators or senior executives know until they see the findings. This apprehension around the use of physician or patient level data can make a physician engagement, participation, or recruitment difficult. Any comments from that perspective?
That's Ross. I mean, I think the key element here is to put the physicians in the room when those decisions are being made. I mean, it's the data, they have a stake in it. There's going to be nervousness at many levels about how the data is going to be used, and we have to engage everybody who has some of those worries into the dialogue about how we use that data most effectively.
And thank you, Ross. Any other comments from the other panelists?
No.
Okay. So we're heading into the finish here for this session. I'd just like to invite any of the three panelists to make any closing comments.
Well, I have no much to add, Larry. I think the discussion was very interesting and informative, and I think many of these themes, we found some parallel in the literature, so it's somewhat reconforting, and thank you.
Okay.
Yeah, it's Brad. Nothing further to add.
Yeah, I'm good, Jennifer.
Okay. Well, I just want to thank you all again for joining, and a special thank you to the speakers, Brad, Jean-Louis, and Ross. I've posted here their contact information that you'll have it when the slides are sent to you. And as always, please contact CIHR if you have any questions or would like to follow up in any way. So with that, so I'll close today's session, and we hope to see you on future webinars. Thank you.
Thank you.